Hello everyone, my name is Chen Yijie. Today I'm presenting a psychotherapy treatment plan titled Treating PTSD with EMDR, a structured intervention plan for post-accident PTSD. Let's start off with introduction of case study. Philip is a 60-year-old white British man who developed symptoms of post-traumatic stress disorder, also known as PTSD, following a serious road traffic accident. The driver of an adjacent car fell asleep and collided into Philip's car from the side while his daughter and grandson were passengers. Philip's vehicle made two spins. He tried to look about to make sure they were safe, but he was trapped. He was unable to see his daughter and grandson. Eventually, the vehicle landed on all four wheels. Philip claimed that he had extreme pain in his back. During the incident, he assumed they had been mortally harmed, which caused him to be overwhelmed with fear and incapacity. Philip's family survived, but he suffered from rehearsed intrusive memory, anxiety while driving, nightmares, avoidance behavior, and increased physiological arousal. These symptoms seriously hindered his everyday functioning, affected family connection, and resulted in social withdrawal. He presented for psychological treatment with the goal of elevating trauma-related distress and regaining a sense of safety and normalcy. Next, we will dive into case description. Demographic details, as I have mentioned before. His name Philip, a 60-year-old male. Cultural background is white British. Occupation not specified. His current symptoms and challenge including intrusive memory of the accident, anxiety and flashback while driving, particularly on motorways, difficulty sleeping, hypervigilance, trouble concentration. Avoided contact with his grandson and his daughter due to guilt. Suppression of trauma memory caused memory unclear. He could not remember that the car has rolled twice until he was told by his daughter. And he also experienced somatic symptoms like hot and sweaty and back pain. This back pain acts as a constant reminder. And he also has cognitive distortion. He strong belief that the accident was his fault, that he cannot keep loved ones safe. So, before the accident, Philip enjoyed family activities and social outing. After the trauma, he withdrew completely. His guilt led to emotional distancing from his family, and he stopped doing things he used to enjoy. These changes caused further isolation and low mood. So, I chose cognitive behavioral approach, particularly if EMDR for this case. EMDR, eye movement desensitization and reprocessing, is a structured evidence-based psychotherapy developed by Francine Shapiro in the late 1980s, guided by the adaptive information processing model to treat trauma-related disorder. Unlike traditional cognitive behavioral therapy, EMDR does not require detailed discussion of the trauma, homework, or challenging belief in the way CBT does. In short, EMDR is a trauma-focused psychotherapy with roots in the cognitive behavioral tradition but based on a distinct theoretical model. It supports the reprocessing of traumatic memory by using bilateral stimulation, while the client focuses on distressing imagery so they are no longer emotionally overwhelming. The fundamental concept of EMDR is that traumatic memory gets stuck in the brain's information processing system, specifically in the hippocampus and amygdala. Distress, flashback, and negative attitudes remain brought on by this unprocessed memory. EMDR employs bilateral stimulation, include tapping, side-to-side eye movement, or verbally toned. While the client concentrates on painful memory, the stimulation appears to help the brain process the memory adaptively by associating the memory with less distressing and more realistic information. Why EMDR? So, EMDR is particularly well suited for Philip's case due to the presence of clearly identifiable single-incident trauma, which is strongly associated with the development of PTSD. According to the World Health Organization and the American Psychological Association, EMDR is recommended as a first-line treatment for PTSD. In randomized controlled trials, 84% to 90% of single trauma clients no longer meet criteria for PTSD after just 3 to 6 EMDR sessions. Unlike traditional talk therapy, EMDR does not require detailed verbal recounting of the trauma, making it appropriate for clients like Philip who experience distress while discussing the event. Traumatic memory is strongly linked with fear and helplessness, activating the amygdala, the emotional alarm system, and hippocampus, which is responsible for memory processing when recall. This caused the past to feel like a current threat, triggering intense distress. During EMDR, bilateral stimulation, for example eye movement, engage brain regions such as the prefrontal cortex, which help regulate emotion. This reduces the amygdala hyperactivity, allowing the memory to be reprocessed and stored without the original emotion intensity. As a result, Philip can recall the event without being overwhelmed. Next, Philip's core issue is PTSD developed following a serious road traffic accident and depressive symptoms such as low mood, unmotivated, persistent upset. He shows cognitive patterns like rumination and thought suppression. Behaviorally, he avoids driving and socializing. Emotionally, he distances himself from loved ones. His relational difficulties are rooted in guilt and shame, all of which maintain the PTSD cycle. Next, I will discuss about treatment goals. For long-term goal, we aim to fully reprocess and integrate the trauma memory, restore functioning in relationship, especially with family, and eliminate self-blame and adopt adaptive self-perception. For short-term goals, we aim to reduce suppression of intrusive memory, nightmares, hyperarousal while driving, persistent thought about his perceived failure to protect his daughter and grandson, and deliberate avoidance of spending time with his daughter and grandson, reduce avoidance using motorways, and overcheck surrounding traffic while driving. So, this is the structured session plan. The treatment followed EMDR standard 8-phase protocol over 12 sessions. Phase 1 is history taking and case conceptualization. So in this session, our goal is to assess trauma history, symptoms profile, and treatment readiness. Our activity include clinical intake and trauma history, establish presenting symptoms and clinical goals, administer assessment tool to measure the severity of the symptoms, identify potential trauma targets. Moving on to phase 2 preparation. In this session, we will psychoeducation on EMDR model and PTSD. And we also practice bilateral stimulation by using non-trauma content. This aims to build therapeutic rapport and trust. And moving on to phase 3, target memory assessment. In this session, our goal is to activate target memory and establish baseline measure. We select first trauma target and we define the following target image. For example, car spinning, negative cognition, he couldn't protect them, positive cognition, they are safe and he did what he could do. And rate validity of cognition 1 to 7 and subjective unit of distress 0 to 10. We also identify somatic sensation, for example, sweaty, hot, and back pain. Phase 4 is where we begin the desensitization process. In this session, our goal is to reduce emotional intensity and distress linked to trauma. Activity include begin bilateral stimulation while holding the target memory, plus the negative cognition and the body focus. Short bilaterally stimulation step will be conducted with verbal check-in. In session 5, we will continue reprocessing the same memory while we also monitor subjective unit of distress and track spontaneous shift in emotion, insight, or body tension. Phase 5 is now where we start to do installation. After reduce the emotional intensity, we now aim to strengthen adaptive belief. Our activity included install positive cognition, like they are safe now, and he did what he could do, and use bilateral stimulation to strengthen the connection between memory and adaptive belief. We aim to reach validity of cognition increase to 6 to 7. Phase 6 is body scan. So in session 7 and 8, our goal is to identify any residual somatic distress. We recall memory and positive cognition, and we scan body for residual tension. If somatic distress remain, use bilateral stimulation to resolve it. This is to ensure complete cognitive and somatic resolution of the target memory. In session 9, we continue processing and functional re-engagement. This is same as the previous session that we do desensitization. The only difference is that we target on new memory. Instead of explaining, I will do a demonstration for better understanding. Hi Philip, in today's session, we are going to reprocess the flashback memory when you are driving on roads and the belief you think the accident will happen again, in order to resolve your anxiety when you're driving your car. Before we begin, we will practice the eye movement setup. I will move my hand while staying seated in front of you. Please focus on the tip of my finger. I will move it from side to side. I do like you to follow it with your eyes, going as far left and right as you comfortably can. Today, we will be trying two types of eye movement, fast and slow. We will start with the fast speed and then move on to the slower one. Yes, this is how the desensitization process. are conducted. And in session 10, same as before, we started install positive cognition related to second target and strengthen functional belief. In session 11, we body scan both target memory and reprocess any remaining trigger or distress. We explore relational healing, for example, re-engaging with family. Session 12, we now come to phase 7 and 8, closure and re-evaluation. Our goal is to assess symptoms changes and determine if more targets are needed. We review treatment outcome by using PCL5, PHQ-9, and GAD-7, this assessment tool, and discuss reduction in avoidance, improve sleep, and emotional reconnection. We also develop a relapse prevention plan, for example, what to do if intrusive memory resurface, and we summary the progress and celebrate progress and process termination. Next, I'm going to discuss about anticipated challenge we might face during the therapy and explore possible therapeutic implication. First, challenge will be the therapy dropout of disengagement risk. If emotional intensity becomes too high or progress is lower than expected, Philip may disengage or withdraw from the therapeutic process. We can resolve this by set realistic expectations, reinforce early wins, and create a collaborative treatment plan with consistent check-in. Second, impair access to full memory. As I mentioned before, Philip could not recall that the car has rolled twice until told by his daughter, an indicator of memory fragmentation, while this is common in trauma where the memory remains unprocessed. This may require more time during the assessment phase to establish a clear target and accurate memory components. Third, avoidance of trauma-related content and trigger. Philip avoid motorways, thinking about the accident at night, and even emotional closeness with his family. This could be resolved by building trust early and reinforce the rationale of trauma confrontation. Begin with less emotionally charged material if needed. Finally, emotional overwhelm during processing. Philip trauma involves intense fear, helplessness, and perceived loss of loved one. Reliving this moment, even briefly, may trigger overwhelming emotional response or panic-like symptoms. The therapist must closely monitor his window of tolerance and be ready to slow down or return to stabilization techniques such as grounding or safe place imagery. From this case, I've learned that while many therapy models are helpful, what matters most is choosing the right one for the client. Therapy should be tailored to the person's needs, emotions, and readiness. I also gain a clearer understanding of EMDR structure approach and how it helps reprocess trauma at both emotional and neurological level. My reflection on the therapist's role is to support the client's mental well-being by applying professional psychological knowledge, offering guidance, and creating a safe and structured environment for healing and growth. And here is the reference that I use in the slide. And thank you for watching.